Welcome to our masterclass on one of the most critical injuries in all of orthopedics, the femoral shaft fracture. Mastering this isn't just about acing your FRCS exams, it's about knowing how to make those crucial, often life-saving decisions when that patient rolls into the trauma bay. So here's our game plan. We'll kick things off by understanding exactly why this is such a high-stakes injury. Then we'll get into the nitty-gritty of the anatomy and the classification systems that are going to guide our treatment. From there, it's a deep dive into the undisputed gold standard, intramedullary nailing, and we'll unpack the key surgical debates. We'll wrap it all up with a look at potential complications. Let's jump right in. All right, first things first, let's establish the stakes here. Before you can even think about treatment, you've got to appreciate the huge physiological hit the body takes with this injury. A femoral shaft fracture is never just a broken bone. It's a massive systemic event. And this number right here is why. 1.5 liters. Just think about that. A patient can easily lose that much blood from the fracture ends right into their thigh, and that can send them spiraling into hemorrhagic shock fast. This is exactly why getting that bone stabilized early is so incredibly important. Now, who gets these fractures? Well, what's really interesting is that it's a tale of two completely different patients. You've got your young patient, usually male, after some kind of high-energy trauma, like a car crash. With them, you have to be on a relentless hunt for other associated injuries. Then, you have your older patient, often female, who suffers an osteoporotic fracture from a simple fall. They present a whole different set of medical challenges. Knowing which of these two patients you're treating is absolutely fundamental. Okay, so now that we know why this is such a big deal, let's build the roadmap for treatment. Getting a rock-solid grasp of the anatomy and how we classify these fractures, that's not just for passing exams. It's the foundation for every single move you're going to make in the operating room. And this slide is a classic. You will for sure see this on an exam. The powerful muscles in the thigh are literally pulling the bone fragments apart in predictable ways. That proximal piece gets pulled up into flexion, out into abduction, and rotated externally. Meanwhile, the distal piece gets pulled inward and shortened. If you don't understand these forces, you have no chance of reducing the fracture. So how do we classify them? First up is the Winquist and Hansen classification. The beauty of this system is its simplicity. It focuses on one critical thing, comminution, or how many pieces the bone is in. This tells you how much cortical bone is still touching, which is a direct measure of how stable the fracture is. A grade 0 is super stable. A grade IV has no contact at all. It's completely unstable. This directly informs your surgical plan. Then we have the AO/OTA system. Think of this as the universal language for surgeons. For a femoral shaft fracture, the code always starts with 32. The 3 is for the femur, the 2 is for the shaft. Easy enough. Then the letters A, B, and C tell you how complex it is. A is a simple two-part fracture. B has a wedge fragment. And C is multifragmentary or highly comminuted. It takes all the guesswork out of it. So we've defined the injury. Now, how do we actually fix it? For almost all adult femoral shaft fractures, there's one answer, one undisputed champion, the intramedullary nail. And here it is in action. Just look at this X-ray. That long rod right down the hollow center of the bone, that's our intramedullary nail. It acts like an internal splint. And because it's a load-sharing device, it provides this incredibly strong, stable fixation that's absolutely key to getting patients up and moving again quickly. And the advantages? They're just overwhelming. The union rates are sky high. The approach is minimally invasive, so we preserve all that good biology of the fracture site. Patients can put weight on it early, and, maybe most importantly, in a patient with multiple injuries, getting that femur fixed within 48 hours drastically cuts down the risk of deadly pulmonary complications like ARDS. It's a lifesaver. But deciding to use a nail is just step one. Now we get to the real surgical debates. And the first big question is, where do you start the nail from? This brings us to a major point of discussion, the antegrade approach from the hip versus the retrograde approach from the knee. This decision really boils down to a tale of two joints. If you go antegrade, starting up at the hip, you risk hip-related problems, pain, stiffness, maybe some damage to the abductor muscles. If you go retrograde, starting down at the knee, well, you risk knee pain and potentially damaging the cartilage in the joint. But that retrograde nail is an amazing tool to have in your back pocket for specific situations, like a polytrauma patient, someone who is morbidly obese, or in that classic floating knee injury. And what does the evidence say? Well, a major meta-analysis basically confirmed what surgeons have known for a while. When it comes to the most important outcomes, like union rates and reoperations, there's no real difference. Antegrade nails cause more hip pain, retrograde nails cause more knee pain. So in the end, the choice really comes down to the specific patient in front of you and, frankly, the surgeon's own experience and comfort level. All right, on to the next critical decision you'll make in the OR. This one has been a hot topic for decades. Do you ream the medullary canal before you put the nail in? To ream or not to ream? That is the question. This whole controversy is a classic orthopedic face-off, biology versus biomechanics. Reaming means widening the canal, which lets you put in a bigger, stiffer nail. That's a huge biomechanical advantage. On the other hand, the argument for unreamed nailing was that you preserve the blood supply inside the bone. The historical fear with reaming was always that you might damage that blood supply or shower the patient with fat emboli. The question was always, what's more important for healing? Well, after years of debate, the modern evidence is a slam dunk. This huge meta-analysis showed that if you ream, your odds of the fracture not healing, a non-union, are drastically lower. The odds ratio was 0.14. That means reaming makes a non-union about 7 times less likely. I mean, that is a powerful, powerful statistic and a critical exam point. So the verdict is in, and this debate is largely settled. Reamed nailing leads to faster healing, much lower rates of non-union, and fewer patients needing to go back to the operating room. And, this is crucial, modern evidence shows that it does not significantly increase the risk of ARDS or mortality. So for the vast majority of cases, reamed nailing is the way to go. It's a standard of care. Finally, let's be real, no procedure is risk-free. So we need to cover the key complications you have to be watching out for, and then we'll summarize the big takeaways from this whole discussion. First, the big one, non-union. And for your exams, you absolutely have to know the precise FDA definition. It's not just a bone that didn't heal. It's a fracture that hasn't healed 9 months after the injury and shows no signs of healing for 3 straight months on x-rays. You have to know that definition cold. And it's not just about non-union. You have to keep these other bogeymen on your radar. Fat embolism syndrome. It's rare, but it can be devastating. Infection is a constant threat, especially with open fractures. Malunion, particularly a rotational deformity, can be sneaky but really disabling. And never, ever forget about compartment syndrome. It's an absolute orthopedic emergency, and you diagnose it with your hands, not with a machine. And that brings us to our final thought. As we saw with that antegrade versus retrograde debate, sometimes the very best evidence doesn't give us a clear winner. It just gives us a series of trade-offs. This forces us to ask a really fundamental question about what we do as surgeons. When the data shows us it's a toss-up, the final decision rests on our experience, our judgment, and, most importantly, on the unique needs of that individual patient right in front of us. And that's where the art of surgery really meets the science.